it's a challenging question because there's a couple of different populations in there. You think about high-risk stage 3 disease, groups where the majority of patients are going to have a relapse. There is I think the clinician's answer to when we ought to do testing. There's a medical economist's answer to when we ought to do testing, the regulator's answer. And then there's, I think there's the kind of the scientific answer to that. On the one hand, I think there's a strong argument moving forward that by doing comprehensive sequencing of really tumors at every stage, of patients at every stage, whether it's stage 3 or stage 4 or even earlier, that contributes to the body of knowledge in a way that's going to allow us to both decrease the risk to patients by hopefully defining patients who don't need treatment, but also then increase the benefit to patients not only by getting the right drug to the right patient in that moment, but also by accelerating drug development. Because this is one of the great frustrations we have nowadays, is there are things which seem clearly promising, but the clinical trial process and the drug development process might take several years. And in the meantime, patients are progressing, and patients who might benefit from that drug aren't going to be getting it. From the economic perspective, this is something we'll always struggle with because, of course, regulatory bodies have to address this issue. But it's not cheap to do testing, and so they're going to say, you have to select the right group of patients. This conversation is probably akin to what you would see for mammography in breast cancer or PSA testing in prostate cancer. Very controversial issues anytime those guidelines are changed at all. I do think that there is space for the patient and the clinician to think about the individual situation and think about how high is the risk of disease recurrence here, and is it worth getting baseline testing? I think the answer is very frequently yes.